All right, everyone. It's a little after 2 on the Pacific here. I want to get Dr. Julian started. I appreciate everyone jumping on this call. Dr. Julian's been one of our key opinion leaders now for a few years, does an awesome job, goes around the country speaking on behalf of PreXion. I'd like to thank him. He practices out of South Carolina, has a school out there where he teaches a bunch of doctors how to do implants. This is course number 2. This morning he did one kind of a beginning course. This is the second installment. So without further ado, Dr. Julian, take it away. Thank you.
Thank you, Tim. So for any of you that were on this morning's conference call or conference, this is just a continuation, but we're going to go a little bit deeper. I'm assuming most of you in the audience place implants. Typically in an audience, some people will place anywhere from 50 to 100 a year. A majority of general dentists place anywhere from 12 to 20 in a given year. And so part of what we want to do is talk about the technique, but at any time if you have a question, please ask, because we find it pretty easy to place somewhere between 300 to 500 implants a year. And it's because I see implants as just a practical, normal part of everyday dentistry. Of all the implants we place, 70% of them are single tooth. So we want to start today by looking at a single tooth implant scenario and carrying that forward, and then talk about the different techniques there are and different problems we might run into and how to solve some of those problems. I'm not a guy that asks you to memorize 20 steps or 10 steps. I'm the guy that wants you to think through each implant case individually. So we're going to talk about individual cases. So some of you may own a cone beam. Some of you probably don't own a cone beam. Let me say this. When I got a cone beam 13 years ago, I thought it was strictly to do implants. And what I've learned is the cone beam is the heart of my practice. Whether I did implants or not, I should have a cone beam. So for diagnosing, treatment planning, patient education, for learning any new procedure, doing any new procedure, every technique begins with the vision and information a cone beam provides. It is the single most beneficial tool for patient education that I have. And for me, I cannot diagnose without it. I can't do 2D. To emphasize that point, I would like all of you to take a look at this panorex. And what you see is an implant in the film that looks like it is spaced out mesiodistally reasonably well. It looks like it's buried below the crust of the bone and probably has a reasonable contour on it. And everything about this picture makes me want to say that implant looks pretty good. However, I've got some doctors who will say, well, it looks like it might be close to the mental foramen. And to that, I challenge you to draw the mental foramen in and conclusively tell me it's there. The problem is we're only seeing one dimension of the implant and of the bone, and that dimension is even skewed. We've got distortion and magnification involved. If I told you that the patient's having a problem with the implant, let me show you why I think they're having a problem. I just switched from the 2D now to the 3D version of that same picture. And on the 3D version, when I look at the bone, from the crust of the ridge down to the inferior border of the mandible, I don't see the entire implant. When I go over here and I can see the entire implant, I cannot see all the bone. Now, the question is why? Well, this is called a sagittal view. When I take the sagittal view and switch it to a coronal view, which is front to back, all of a sudden what I see is the implant exiting the bone on the lingual. So it looks on a 2D picture like it's reasonable. It looks on a 2D picture like it might approach the mental foramen, but that's because the mental foramen is facial to it by several millimeters. And so it's a distortion of the facts. The green line you see here is what you're looking at when you switch to that that sagittal view. So all I'm looking at is a line through the middle of the implant. And if I go through the middle of the implant, I cannot capture the bone. If I change that line and tilt it so it goes through the bone, it cannot capture the implant. So by having a third view, a three-dimensional view, I can see the problem with the implant. Now, if we look carefully, this implant is tilted, and because it's tilted, it drives the facial part of the implant inferiorly, which drives the margin of the crown inferiorly, which now creates a problem with the tissue. Here's a picture of the tissue around that implant, and we're now into the soft mucosa with muscle attachments around it, and the patient has irritation around this constantly. So the doctor didn't use a cone beam. He placed the implant what he thought was reasonably well, and two-dimensionally, he could not detect the problem. But the patient has a three-dimensional problem here, and the solution for that implant, unfortunately, is if she wants the problem solved, is to take it out and replace it correctly. These are the problems we want to avoid. We never want to get into a scenario where we're putting the implant anywhere but in the bone. Now, having said that, let's go into a case scenario. Here's a patient that came to my office 5 years ago. He was going to lose an upper central incisor, and a discussion was had about doing an implant. He elected to leave my practice, go elsewhere, and have the bridge done because it cost less or because the insurance paid for it. I never know the reason. I treat people as nicely as I can, and if they leave my practice, I assume it's for something other than the way they were treated. So I'm going to assume the insurance paid for it. Well, we're now 5 years later, and the patient is back in my practice. Why? Because he doesn't like his bridge, because it's causing a problem, and because he now has a problem on the upper left. So what I want you to understand is, when somebody says no, but you've done the best that you can, there may be a yes coming down the road. When we look at a patient like this, the first question I ask him is, what's wrong with your bridge? Because he complained about it. And he said, every time I bite together, I touch it first. So I looked at his bite. Look at the lingual erosion. This patient has vertically closed as he's worn and eroded into his teeth. As he's vertically closed, he now has a high spot on areas that are not eroding as fast. So now we have occlusion only on the bridge. We've also broken an endodontically treated tooth here, and we've broken a vital tooth here. When he closes, I actually measure the vertical distance by measuring the CEJ of the upper central to the CEJ of the opposing lower central or lateral incisor. And I get a number, and that number doesn't mean anything to a lot of people, but if it approaches 18, give or take a millimeter or so, then that's a pretty good number. He measured somewhere around 14. So I know he's overclosed, and I know it's by 3 to 4 millimeters. I'm looking at occlusion. I want to know what's going on and why we get abfraction and why we have broken teeth. I look at the nutrition aspect. There's a lot of acid either coming or going or both, and that's causing the erosion plus clenching, grinding his teeth. So let's say I wanted to put a crown on this tooth. Well, I know I've got an occlusal problem, and there's not much space to create a crown. Tim, did we just lose the image? Let's see if I can get back to it. There we go. So by doing this, I'm looking at dentistry and occlusion, but I'm thinking implant. And if I'm going to do an implant here, I need to know some dimensions. I need 7 millimeters from where the occlusion is here to where the base of the implant is up here. That's the amount of space it takes to put an abutment and a crown. So that number pushes me deeper into the alveolus with my implant as the vertical dimension is closed. So we have a discussion with patients like this and say, do you want to correct your whole bite or just this area? Most of them will want to correct just the area. That's okay, at least we had a discussion. Now, having gone through the discussion, the patient says, you know, I think I would rather have an implant than to have the tooth rebuilt, the one that broke. So we're going to do an implant for number 13, and we're going to do a buildup and crown on number 14. So the first thing I need to know is, what's the dimensions? And I have 3.98, almost 4 millimeters of width, and I have about 10.5 millimeters of height before I get to the sinus. So I begin to develop sizing and position of implant. So I take an implant, for example, a 4 by 10 millimeter implant, and I virtually place it on my cone beam. Now again, I can't do this on my panorex or my PA. That implant goes in, and I can see it in an axial view, a sagittal view, and a coronal view to determine. On the coronal view tells me the buccal lingual position. Sagittal tells me the mesiodistal position. And the axial allows me to run up and down and see it in all 3 dimensions as I'm moving vertically up and down. Now I go to the clinical scenario. I've cleaned up number 14. I do a buildup on 14, get it ready for the crown. And then I go to number 13. I extract the tooth, keeping the buccal plate intact, and now I'm ready to do an implant. The socket's cleaned, and a Megagen implant, that's what I'm using right now, is placed as diagram. And notice the gap I created between the implant and the buccal wall. There's a lot of discussion out there, and a lot of people have opinions about socket grafting or filling the gap with the graft. And I'm going to tell you that my personal opinion is this, is if I have an intact buccal wall, then I fill the space with platelet-rich fibrin. I do not put any graft material in that space. I also do something now that very few of you may be familiar with. I do something called an ISQ. I place a probe in the implant. I use an ostel to give me a number. In this case, the 4.5 by 11.5 millimeter implant was placed, and the ISQ numbers were 52 to 56. Now, this is important because when we place an implant, a lot of us think, and this is me even a year ago, that by inserting it to a certain torque value, let's say 40 Newton centimeters of torque, that gives me an indication of what the stability of the implant is. Well, it only tells me at a moment in time that was stable. From this point, now the bone tends to die around it and the stability decreases for the next 6 to 8 weeks. The only way to measure that after that 6 to 8 week period is to stress the implant again. So if I stress it again, that means putting a device on that literally tries to turn the implant and then reading the amount of torque that I have before the implant turns. And if any of you have ever done that, your stomach turns as the implant is sitting there and you're trying to determine whether it's stable or not. So the purpose of the ISQ device is it gives you, with magnetic resonance, a vibrational number, and that number, if it hits 70, says you are stable. So I got numbers of 52 to 56, which says, John, you're stable, but you're not stable enough to put a temporary on or to do anything in the way of load on that implant. It also gives me a reference point when I come back at 3 months. Once I'm done, I've got my readings, I put my healing cap on and my platelet-rich fibrin goes in that gap on the buccal. Temporary crown on the back tooth. So understand that when we're doing anything in the way of surgery, removing a tooth, we create a wound. We want the wound to be healed, and so we graft it. We graft it trying to create a scaffold that holds a blood supply, and that scaffold can be allograft or it can be platelet-rich fibrin. Now, what's the difference? Well, the allograft costs a lot and it's a foreign body. The platelet-rich fibrin, on the other hand, is the patient's own tissue. It costs almost nothing to collect. And I put that in there and it actually speeds up the healing because it allows for a concentration of normal physiological cascade of events. It helps create a blood supply faster, an organized blood supply. It signals molecules the minute it goes into place. It helps create the cells that take to rebuild the structure. So platelet-rich fibrin rebuilds the ridge or the socket faster, less expensive, and you've got a ready supply of it on hand, so less costly. So I find it to be a very handy material to work with. When I get done, I take a PA. Now, I do this because insurance companies demand PAs. I also do it because I want to know that grossly I didn't run into anything I shouldn't have run into. But does this picture tell me accurately where the implant is buccolingually? No. Does it give me an accurate representation vertically of the height? No. It's distorted. You can see the way the threads are not perfectly perpendicular. So this is just an indicator picture. It's not a picture that I put a lot of value in. Now, one of the issues we have with placing implants is thin tissue. So this tissue out here, as the ridge has resorbed in, has really gotten thin. It's no longer keratinized up high. However, there is a zone right across here that is keratinized. So I'm going to place an implant here, and I'm going to begin by making an incision back where the keratinized tissue is and moving that tissue forward, buccally. In this case, I'm actually doing 2 implants. When I place the implants, I take the tissue and I simply lay it up against the healing caps, the healing abutments. The suture is meant to stabilize the tissue. It is not meant to close. So from this point to this point, I have a 3 millimeter gap. There's nothing covering the bone. But the body is going to fill that in with fibrin. So fibrin is what we form when we have a wound. I didn't use platelet-rich fibrin here because it was a minor surgical entry. But watch what happens. At 3 months, we come back and we are forming a nice zone of keratinized tissue where there wasn't any before because we simply transplanted it from here back over to here. And look what happened between the implants. Naturally grew the tissue back in to cover the bone. So now I have my 2 implant crowns in, and I have a nice zone of keratinized tissue, which will help support biologically the health of those implants. So I always like to do this in a way that gives you the most up-to-date cases I'm working on. So here's a case I just recently did. We're going to extract this tooth, place an implant here, and an implant for that tooth. The problem is that the keratinized tissue has receded over time up to this zone right here. So what do? I make an incision lingually. So I can bring what little keratinized tissue I have buccally. Extract the tooth. This one was prepared for a crown. Now I take my flap and look at the bone. I can create an osteotomy site here and in here. The osteotomy sites now are completed, and I have total vision, and I can place my implants. Here again, we have a Megagen implant going into place. And now I'm covering both implants with platelet-rich fibrin again. There's a platelet-rich fibrin membrane that I formed. When I close, you can see that I have not made any attempt to make primary closure. What I would like is the tissue to actually be facial to its original position. And if it stays out there, fibrin will help fill in and form tissue over all of this. When I start restoring the implants, again, I will have keratinized tissue now facial to the implants. We did get a question, how long do these sutures stay in? Well, I use resorbable sutures, and what I find is I'm taking these sutures out in a 5 to 7 day period typically. The platelet-rich fibrin stabilizes and helps tissue to begin to form and scar tissue to grow in very rapidly. So typically 5 to 7 days. I can take them out as early as 3 days in some cases, but I don't leave the sutures in for very long. All right. So let's go back to the issue of the cone beam. I want you to notice the white underline here, the date, 4/29 of 2014. This patient came in. We did an exam. There was no problem. That tooth has had endodontics, restorative work done. Somebody might have done something surgically and shortened the root. I'm not sure. But everything is perfectly healthy and comfortable to her. She comes back 4 years later. And at that time, we took a look. At that time we did a routine exam, and the tooth again was looking very good. So there's no reason to take another cone beam except that from 7/31 of 18, 4 years after the first one, something happened 15 months later. And she comes in with this, what looks like abscess. So we took another cone beam. That cone beam now shows that in 15 months, we have developed a rather large abscess that's beginning to destroy the bone on the facial plate. So we discussed the options. She was a person who was very reasonable. There's the tooth is out, the platelet-rich fibrin is in, there's no implant yet. Notice how the platelet-rich fibrin goes completely to where that abscess was exiting the tissue. I take a CO2 laser, I clean that infection up, I clean it out. Then I put platelet-rich fibrin up through the socket till it comes out. And now I've accelerated the soft tissue healing and the hard tissue healing. And it also helps to it helps to get rid of anything that could be infection or tissue that's bad. The platelet-rich fibrin just speeds up the entire healing process. Now she comes back 3 months after that has been done, and the bone has not matured, but I want you to notice the bone's filled in, and there's the buccal wall, just where it was with the tooth. So I draw in what I think my dimensions are so I can get the most constricted point, and I know it's 3 millimeters. Most of my implants are 3, 3.5, 4, and the very tip of the implant is typically the narrowest part. So about 3 is as narrow as I wish to go. Next, I'll measure the length of that, which is 12. So if I know I can go 12 millimeters deep, before I get to that 3 millimeter point, I might choose to put a 10 or an 11.5 millimeter implant in. Where would I like to be in alignment is I'd like to be into the middle of the crown. So I align where I'd like to go. I now have some degree of guidance for when I put my message in or put my implant in. There is the narrowest point. Very easy to visualize. Now I go back and virtually place the implant into that space. And that's a fairly tight fit, but I can get it to the incisal edge so the implant is on axis, and I can get it here if I perhaps expand the bone. So we're going to talk a little bit in a few minutes about expansion versus removal of bone. Most of you are probably using traditional drills that are removing bone to help size an implant, and you slightly undersize the osteotomy, and then the implant goes in with some stability. There is a method to expand bone when you're really tight like this. So I'm going to use an expansion device. Now, what's interesting is, as I'm looking at this patient who went through orthodontics as an adult, I started getting curious as to the length of teeth and the amount of bone under the teeth. So she has almost no bone here, and the tooth is only 15 millimeters tall. For those of you who do endo, an average tooth like this is usually 18 to 20. So we have some root resorption going on, and it hasn't done the bone any favors. If that tooth comes out, I've got a problem putting an implant in. So here we are clinically now. We've measured the bone. We know what size implant we want to use. We go in and make an incision. Now this incision is mid-crest as opposed to lingual, because I have nice keratinized tissue out here. We release the flap, a small envelope, just enough to see the tissue or to see the bone, make the osteotomy, and now I'm going to insert the implant, and I have expanded this bone slightly. The implant goes subcrestal. Again, once I put the healing abutment on, I'm simply going to lay the tissue up. I'm going to put sutures in to stabilize it so the tissue doesn't move, but I am making no attempt to close this area. That I've been asked by doctors over and over again. Well, am I not going to get infection in there, debris in there, bacteria in there, food in there? And the answer is probably, but it's all going to come out. All you have to do is let the body now fill this area in with fibrin. There's the radiograph of the implant in place, and the implant is designed not just for the tooth I'm replacing, but for the bone surrounding it, for the constriction in the bone, which I know is right up in this area where the narrowest part of the implant goes. I know I'm mesiodistally centered, and I know buccal I'm in good shape. A 2D picture like this doesn't give me all that information. I know that from my cone beam. Now, a question I get a lot is, what do we do for pain management? And I've been one of those doctors that over the years, I've always avoided the prescription drugs. So I use 400 milligrams Advil with 500 milligrams Tylenol in combination. You could use Norco 5-325 as an option in today's climate. I will tell you the last prescription I wrote for Norco was sometime last year. Antibiotics, I do not give antibiotics routinely. If a patient has a specific need, if their physician has said they need an antibiotic or they would like an antibiotic, then I will use either amoxicillin, clindamycin. If I find that I have a real need, augmentin, Biaxin, or erythromycin are all usable. But I have to have a reason for using any antibiotic. I use amoxicillin as a general rule and clindamycin if they can't use amoxicillin. But I really minimize any use of antibiotics. In the face of what we're facing right now, antibiotics are not going to stop a virus, but any kind of bacterial problem that comes along that we have difficulty handling, part of it's because we've overused the antibiotics and these bacteria continue to mutate, and pretty soon the antibiotic doesn't work. So the less we use, the better off we are when we need them. So let's go through another case. Here we've got a 20-year-old female, and she comes in and she has a lateral missing and minimal bone, 3.5 millimeters of bone here. I'm sorry, 5.9 here, 3.5 here, and 5 here. Well, 3.5 is not enough to place an implant in a 20-year-old and have it be aesthetically successful. So in this case, we took and did a graft and built the bone up facially. Now we have the patient back 4 months later, and we're going to place the implant. The facial lingual dimension is no longer the problem, but look at the mesiodistal. That's a real tight fit. So when we have a small margin of error, we do a surgical guide. And I know you're all interested in surgical guides, and I haven't used one yet, but I want to show you why I would and when I would. On a surgical guide, we do a prescription that specifies the size, length, and brand of the implant. We communicate this to a company. This happens to be Implant Concierge. They take the information, what kind of implant, the diameter, the length. They take the cone beam information, you must have a cone beam, and then they get together with you to verify the position of the implant that you would like. They put the crown on it. Now we can do all of this with software of our own, but I find this very handy that once we've got this determined, the right size, the right implant, they then will mill or print a surgical guide. Now, a lot of people who are not experienced in implants will say, well, if I use a surgical guide, I can't make a mistake. And that's completely wrong. A surgical guide, from the reading of the x-ray to the interpretation of the implant position, to the manufacturing of the surgical guide, to the dentist fitting the guide on, there are 5 steps that can go wrong. And if you're off 2 or 3 degrees, that implant can start heading in any direction that you don't want it to. So making a surgical guide is not to be confused with doing perfect implants. And when I do a guide, I typically do it for only one drill. So the pilot drill will go in, and it goes all the way to place. And when I'm done, I got a good result on this case, mesiodistally, and this is what I want to do, is avoid running into the roots of either of the adjacent teeth. Now, the finished restoration, 4 months after surgery, there's the implant crown. We went ahead and did crowns on these 3 teeth. And the implant crown should mimic these teeth. Color, size, shape. It should be symmetrical with this lateral here. If you look closely, what you're going to see is the tissue has not matured in this area. If you wait about 6, 8, 9 months, that's going to mature and look just like this or this. So even though it takes 3 months for bone to mature and grow and stabilize around an implant, it takes longer for the tissue to reach its final. And I give tissue 9 months to a year to remodel and remodel and remodel and mature into spaces. Now, I think most of you know, but if you maintain the height of the contact point, the highest point toward the bone, so let's say it's right where my arrow is, if that point to where the crest of the bone is less than 5 millimeters, I will get papilla to grow in the space. If I have 2 implants side by side, I need to have that number be 4 millimeters. So 2 implants, the papilla is typically blunted, and I need to have that contact point closer to the bone. 2 teeth, it can be 5 millimeters, sometimes a little over, and I will get growth because of the fibers that insert into the surface of the tooth. Here we have no fibers inserting into the lateral, only the central. So the papilla growth is going to be dependent on time and contact point. Different scenario. Now I've got a patient who's been in a temporary for 2 years. You know, you get those patients who come in and they want to do a lot of work and they know they're on a tight budget, and then something happens and it delays them. So we put a temporary on, and for 2 years, from number 7 to number 12, that temporary is held up. And the laboratory did a wonderful job making it. But the patient, because he couldn't finish, also decided to give up his hygiene appointments. So when he finally does come in, we take the temporary off, and we find that number 11 has decayed into the pulp. So we sat and had a discussion, and we told him that we could do a root canal buildup and crown. It would require a post because this is off below the gum line, or we could remove the tooth and do an implant. And in this case, the patient elected to do an implant. So back to our cone beam, because this is so critical to know how thick the buccal plate is and where's the position of the root and the root tip. If I want to put an implant in here, I probably want to go into this bone, not follow the root up here. If I want to take the tooth out, let me give you a little tip on surgery. I go in and I virtually extract the tooth before I go in and with a burr or a forceps, and I'm going to now make a cut right here where the yellow line is, approximately 8 millimeters, maybe 9 long, and I'm going to stop and break that little piece out. Now I have room for the tooth root to maneuver facially as it maneuvers vertically out. And I apply pressure here, and I can get the root out and leave the buccal plate intact. So knowing how deep to cut and in what angle is invaluable to me. That's how the implant will be positioned. So now I simply go to the mouth, cut the root, take it out, and I go ahead and remove the tooth and place the implant, just as I planned it on my cone beam. This is not guesswork. This is planning carefully and then executing the plan. Now, by now you know that I'm going to fill that in with platelet-rich fiber. So as I fill it in, I then place my healing cap, which holds the fibrin in. So many times I don't even have to place a suture in there. And before the healing cap goes on, I do an ISQ development number. And here I got 50, 50, 60, and 60, short of my numbers of 70. So we complete the surgery. Also notice there's no bleeding. When you place the platelet-rich fibrin, it stops bleeding immediately. So I put that in 100% of all extraction sites. The patient returns November 18th, so we are now some 10 to 12 weeks out, and we measure the ISQ again, and we get 60, 60, 60, and 60. So we're in the low to mid 60s in a matter of 10 weeks. So the patient wanted a temporary crown done. They didn't like the removable device, and we put a temporary crown in out of occlusion. She comes back again another 10 weeks later. And now the numbers are 70, 70, 70, 70, low to mid 70s. And remember I said, if I have a 70 or above, then the integration process and the stability of the implant is good enough to apply 30 Newton centimeters of torque. Now I can apply torque to an implant and my stomach loves it. It's not getting upset. So at this point, we did a scan to make a final crown and seated that screw retain crown some 4 weeks later. So I can measure the ISQ again at this point, and if the ISQ is below 70, I will not place the crown that day. Only if it's 70 and above. And since I started doing this, I have not had an implant spin on me yet. So I can depend on the numbers. I'm very comfortable measuring the day of insertion, the day of the impression, and the day that I place the final crown. And those numbers are very reliable and give me peace of mind to know when the integration process has completed. So here's now the patient with final crowns on all of his teeth and a crown on the implant of the tooth that we took out. He is going to come back, he wants to come back and complete the work and do the lower arch. So we're kind of walking along with this patient and letting him determine the pace at which we work. So if I wanted to expand rather than condense the bone, I'm going to go by something called a Versah Bur. And I want you to understand that a Versah Bur is not a burr the way most companies have developed theirs. And let me say that another way. I cannot take my burr out of any of my implant kits and turn it in reverse and get the same effect that this burr has. So I think the gentleman that invented this, Dr. Salwa, took about 60 designs before he stumbled on the one that was going to work the best. So if I take this and turn it clockwise, it's going to cut the bone the way every burr does, and it does it beautifully and very smoothly. If I'm going to reverse this, it's going to leave the bone in place and compact it and condense it. And done with the right technique, which I don't have time to go into the entire technique, but done with the right technique, I can preserve bone, create better stability for my implant, and not remove bone. Now think about that. I'm in a space between two teeth. If I'm cutting bone, I'm in danger of going out the buccal plate, going out the lingual plate, or getting too close to either tooth and perhaps touching one of the teeth. But if I'm in reverse, compacting the bone, I'm literally pushing myself away from those teeth or away from the buccal cortical plate. So it tends to center itself as I'm working and stay away from the danger. So let's do a case and show you a little bit about how we can use that Versah Bur. So number 3 has got an abscess. You can see a large lesion up here. We can define it in the axial, the sagittal views. And then what we do is we extracted the tooth and the patient healed. Now this patient didn't decide right away whether they were going to do an implant, but now they've healed up. We have a nice healed ridge and we're going to do an implant. Well, the first thing I do is I measure the space and I find that the sinus has dropped down or pneumatized into that space. And one of the things you do is as you put more implants in, you get better. So doctor, if you ask me, how can I get better? I'm going to tell you, put in more implants. I know that my width of my gap, my space, is 5, almost 6 millimeters. And if I'm going to put an implant into the space, I need to build some bone. But as I enter into that vertically, a 5 millimeter implant will almost fill that space. So a little graft and an implant will gain stability. I know here I have 3.6 millimeters of space here and 4.6 here. So even though I've got 2.5 at the narrowest point, by the time my 5 millimeter implant is in, it's engaging the wider parts. So by measuring all of these dimensions, I can make a decision as to whether I'm going to place an implant and gain the stability I need the same day. If I virtually place it, that implant needs a lot of grafting to help it. This implant, seen in a different view, needs a little less grafting. And if I can stay in the bone in the center, I should be able to place the implant. 2.5 millimeters is my smallest number of where the bone is. So that's what I have to be conscious of. So what I do is I make an incision. Now I use a laser, a CO2 laser instead of a scalpel. And by using a CO2 laser, there's no bleeding. I also don't have the patient releasing histamines, and therefore it cuts down on any type of swelling, pain, or bleeding later. Once the incision is made, I just simply release the flap, facial and lingual, do the osteotomy site with the Versah Bur, do the grafting that I need to do, and place the implant. Now there's the Versah Bur, which will go in reverse and compact the bone and push it vertically 2 to 3 millimeters. Beyond 2 to 3 millimeters, you need to add some graft material. And once you've grafted up in that area, you will not break the Schneiderian membrane. Now my Megagen implant's going to go in. This is a 5 by 10. So when I insert it, I'm going to do an ISQ measurement. Now you saw how little bone we had, but because we did the compaction and because we preserved the bone and added some graft, our ISQ number started out in the low to mid 60s on the day of insertion. With a healing abutment in place, I now let those little flaps of tissue that I created lay up against the healing abutment and I have no need to do any further work. There's no suturing even needed in this case. The little gaps will be filled in by the patient's own fibrin, natural healing process. And that's a picture of the implant with the graft. So I'm going to show you a case we did a few years ago. This was before I had the ISQ device. And what I want you to notice is the cleft on the mesiobuccal root of number 14. This is a cosmetic patient on the wife of a dentist. He did the work, and we are not always responsible for things like this. When you looked at the cone beam, the bone surrounding the mesiobuccal root was so thin that the tissue was not supported. So we measure, and I measured 5.5 millimeters in the smallest area. I virtually placed an implant. And I thought to myself, well, if I put some graft in there, I can do this. So what I do, extract the tooth, do an osteotomy site in the center, and then take an osteotome and condense and compress that out. Now that worked well, but it was also traumatic to the patient to tap on an osteotome. Graft the site, place the implant, and there we go. Now, here's tissue healing at 1 week. There's the suture we're going to take it out. And at 1 week, what is that white stuff that's filling in around the cleft? Keep in mind the implant is more lingually positioned, palatally positioned than the mesiobuccal or distal buccal roots. So there's a horizontal gap and it's filling with fibrin. At 3 weeks, the fibrin is beginning to turn into tissue. At 3 months, we are now surrounded by healthy tissue, which still has yet to mature, but look at the shape of it. And here we go, ready to restore. Now we have a nice zone of tissue, 2 millimeters, 2.5 millimeters around the abutment complex crown. And so when you look at the height of tissue, that's actually better than where we started, and there's no clefting here. Same tooth, different patient, and done more recently. So as I'm doing implants, I'm constantly trying to evolve to a better solution for the patient with less work, less cost if possible, better tools. So I never think that I'm where I should be. I'm always thinking I'm behind a step from somebody. So here we go, 7 millimeters of bone, 7. Now I know my Versah Bur can actually push bone 2 to 3 millimeters vertically. And if it pushes it 2 to 3 millimeters vertically, I can do this without adding any graft material. I can put a 10 millimeter implant into a 7.5 millimeter space. But I want to know another dimension. How much bone do I have between the roots? And I measured it to be 3.63 and 4 point something. So when I have that measurement, now I'm starting to think, if I start drilling that bone away, when I hit 4, I'm going to be creating less bone to hold the implant. On the other hand, same picture as before, take the roots out, preserve the bone, create the pilot hole. But at this point, instead of removing bone, I am now compacting and condensing the bone outward. And all of this that you see around the rim, the fringe here, is the bone that would have disappeared, would have been gone. So I haven't lost any bone. What you're seeing up in here is a Schneiderian membrane that hasn't been perforated, and I am at 10 millimeters, where I only had 7 millimeters of bone. Now I can place a 4.7 millimeter implant in 4 millimeters or less of bone and have it completely surrounded by the bone. In the gaps, that's going to be platelet-rich fibrin. Fibrins in place, implants in place, tissue formers in, no grafting accomplished on this case. Finished radiograph, 2-dimensional, therefore it's just a gross picture. And now we come back at 3 months. Again, look at tissue around it, look at the nice contours. And now we're going to do a screw retained implant for number 14. Again, look at the tissue contours as normal and natural as they can be. I wanted to take this picture because I want you to notice that the markings from the articulating paper are a little heavier on the bicuspids. We don't want to be full in occlusion here. When the patient bites and taps, I don't want this tooth to really touch, but when they bite heavy, these teeth are actually compressing slightly in the PDL. This has no PDL. So only in maximum bite do I want this marking at all. And then I'll put my filling in here, my composite, and I'll make sure that that hasn't created a high spot. Now, this same patient had an implant in, and that implant failed. So I want you to notice the length of the implant. Somebody put a long implant in here, 16 millimeters, because bigger is always better. That's what we used to think. I extracted that implant, took it out, placed platelet-rich fibrin, and let it heal for about 14 weeks. She was in a hurry to get the next implant in. So I took another cone beam, and what you're looking at here is bone that has not fully matured. Its contour feels as good as the bone did, but it hasn't matured, so it doesn't appear the same on the radiograph. Now, you won't know this until you actually drill into it, the characteristics of it. But I went ahead and I told her we may or may not place the implant today. It would depend on the first drill. But I did a virtual placement of the implant, followed it, went in, and created a really nice implant scenario, very minimal entry. And when I put the healing cap on, it actually created some tension on the tissue out here, which is a good thing. Didn't need any platelet-rich fibrin here. And by the way, the ISQ numbers into that dark-looking, immature-looking bone, high 60s to mid 70s. So we've got tremendous stability in that implant, even though the implant itself is much smaller than the implant that was in previously. At 10 weeks, the tissue has healed with a nice 2 to 3 millimeter zone all around it and depth. So we do an ISQ. That high 60 to mid 70s has now gone high 70s to low 80s in 10 weeks time. So again, am I feeling really comfortable now that I can stress and torque that implant that's been integrated? Yes. I have no thoughts about anything turning or spinning once I know these numbers and I have a relative measurement from the previous numbers. Now I do a lot of digital scanning, so I placed a scan post and did an iTero scan. You can put an impression post in here and take an impression at this point. I do not worry about the tissue contour down here. I just need an opening that I can manipulate with the abutment and the crown. Patient is ready for the crown to be placed. There's my maturing tissue. See how it's getting better with each visit? And now I simply insert the implant, either the abutment, and seat the crown with cement, or a screw retained crown will go in and I tighten it down to 30 Newton centimeters. The screw is either in the abutment or in the crown abutment complex. And in this case, it was a screw retained crown, but you'll see 25 to 35. I'm simply gently going to 30. I'll let it relax for a few minutes and then tighten it a second time. Now I've filled the hole in here. I've not polished the crown yet, but I just want to take a picture and show you there's a little tension on the tissue, but see how beautifully that looks? When you give the laboratory a good scan or a good impression, they'll create the emergence profile. And if you're down under the tissue with your implant, you're going to create a beautiful scenario and have nice, healthy tissue to preserve the biology of the implant going forward. And there's a radiograph of the finished case. Okay. So everybody's going to have failures. Nothing is 100% successful. And sometimes we bring the failures on ourselves by not buying sharp instruments. But when they get dull, they've been used 50 times, they probably need to be replaced. We need to make sure that our irrigation is generous. We need to watch our drill speeds. I used to say slow your drill speed down, but I don't, because if you're using a Versah Bur and you're condensing, the drill speed needs to be a little higher at times. If you're cutting, you need to be aware that your wider diameter drills are turning faster on the cutting edge than a narrow diameter drill, even at the same speed. So it's not about speed, it's about the point of momentum out on the edge of the drill. So just like a bunch of skaters are lined up, and you get the skater in the middle holding hands with everybody else. And as that skater in the middle slowly turns, the skater on the outside edge is turning really fast. He's really moving. So you've got to watch that. And then, of course, please use sterile technique. From the time the patient sits down, everything should be sterile technique. Sterile gloves. I like surgical gloves. Be cautious when you're dealing with smokers, diabetics, people with systemic disease, or patients with medical compromises or on numerous medications. They don't heal as well. They don't heal as fast. You may have more failures, but it doesn't mean you can't do it. It just means you want to be a little more cautious in your conversations with the patients and don't promise things that may be compromised from the very beginning. Now, another thing I like about implants is the ability to utilize them in other types of treatment. So for example, I really don't like doing removable partial dentures. And so here's a case where a patient comes in and says, "Doc, I want you to replace my removable partial denture because I just lost the tooth that was supporting it." And I look back here and the second molar is it's not in very good shape and it's going to be lost someday as well. So we came up with a treatment to not just make a removable partial denture, but to add an anchor on the free end saddle. And now we're not even going to connect it to the second molar. So I use this and I use it frequently. Patients come in and typically they want to buy a partial because a partial is less expensive than doing bridges and implants. And I get it, I understand that. But when I offer them a better partial, a higher quality of the lower cost treatment, they go for it almost every time. When I explain that by anchoring this back here, I prolong that tooth, I don't work that tooth as hard, everything works better and they won't get as many sore spots underneath the saddle. So there's the partial with a cutout area that we're going to now put a locator attachment on and pick up in the mouth. And now we have a traditional partial, except it's implant supported on this upper left side, and it's not attached to the second molar, where most doctors would have put an attachment, a rest and a clasp on the second molar, which in my opinion would have speeded up the exfoliation of that tooth. We might be able to hang on to this tooth now for a few years because we're not stressing it in any way. And the partial snaps in, has better occlusion, greater stability, doesn't move as much. I think we've all had the patient that walks in and says, "Oh, doc, I forgot my partial. It's in my drawer at home." Or they pull it out of their pocket, their shirt pocket, and they say, "Yeah, I don't wear it unless I have to." Well, I have yet to have a patient do that has an implant supported partial. So it's all about stability, and implants provide that. And I don't do but probably 2 or 3 partials a year. But I do 100% of my partials have an implant supporting a free end. And so patients are willing to go that step if you offer it to them. There's your locator attachment in the partial. Now you can carry that to whatever level you want. Here's a patient with overclosure, vertical loss that's excessive, and he wants to keep whatever teeth he can. Well, he's only got 2. So we kept this one for a while. What we did over here is we put implants in with locator attachments on, and now his partial snaps into place. It is removable, but it does not rock or move. And eventually we did lose the tooth over here. And yet the partial still nice and stable. That's him with his partial in. So, tried to get done about an hour, and we made it. And I'm ready for questions, Tim, at this point, and I'd love a little discussion because I went through all the material and I want to make sure people have a chance to ask me questions.